Good morning. I'd like to invite you to our Cracking the Cancer Code series here. We are a team of providers at the Center for New Medicine in Irvine, California, and we're going to talk to you this morning about cancer, the contributing factors to cancer, alternative treatment options for cancer that we do here at our clinic. And I'd like to introduce you to our team. Dr. Leigh Erin Connealy is our medical director, Dr. Bita here on the left, and Dr. Acebedo on my right. And welcome to our Cracking the Cancer Code series. I want to first begin by explaining a little bit about our clinic. We are the largest integrative and alternative cancer center here in the United States. And Dr. Connealy, you've spent the last 30 years learning about cancer, going all over the world to specialists, not here just in the US, but all over the world to other countries, learning about what are those contributing factors to cancer? Why are we getting cancer? How do we treat cancer? How do we treat the whole body, head to toe? Where are the missing links? And you've created an entire clinic here where we have modalities, technology, treatment options, IV therapies. We have various practitioners and technicians that do all kinds of therapies. Can you explain a little bit about all the services that we offer and how we're a lot different than the average cancer clinic, the average integrative clinic?
Well, first of all, cancer is a pandemic in and of itself. 1 out of 2 people are being diagnosed in America, but when we talk to other physicians all over the world, they have the same sentiments and the same statistics. And I'm all about early detection and prevention. Of course, we treat cancer patients all over the world who have cancer, and from every stage of cancer, stage 1, 2, 3, and 4. But of course, we want to prevent and have early detection. But the problem is that doctors don't really know how to detect cancer early and prevent cancer. But I will tell you how we are different. So typically, when you are diagnosed with cancer, with a lump or bump, one place in your body, all over your body, you are typically given the treatment options of surgery, chemo, or radiation. Those may be necessary, and sometimes we have our patients do surgery, chemo, or radiation. But first of all, cancer is a 10-year process. We have to unravel why, where, when did you get cancer? How did this start? And as Heidi was saying, this is a whole body approach, okay? So there's many contributing factors. With corona being diagnosed, they're all talking about underlying diseases that have increased their risk of getting corona and dying of corona. So we as physicians must analyze everything about you. So that includes doing a panoramic blood test of everything. Typically, what we see that doctors around the world do a chemistry and a CBC. Well, that doesn't tell you very much. That just tells me your liver, your kidney, your electrolytes, and whether you're anemic. But we've got to check your thyroid, because thyroid predisposes you to cancer. High blood sugar predisposes you to cancer. Inflammation is the precursor to all diseases. Vitamin D influences all diseases, 3,000 genes in your body. We got to check your DHEA sulfate, because if your adrenals are stressed, you're predisposed to cancer. All of these factors, Dr. Bita loves the PHI test, which he'll talk about in a minute. So we check everything. We check your immune system, because the immune system is the foundational deficiency in many patients and many diseases. So if the doctor of today must address the entire system. Then we do nutritional analysis. What is the biochemistry of your body working? There's something called the Krebs cycle of energy, and that includes vitamins, minerals, what's the toxicity, what's your essential fatty acids, what's the function of your gut, what's heavy metals, what toxins do you have? And then you need to check what are all the bioenergetic findings. Do you have candida? Do you have parasites? Do you have blocks in the system that are interfering with your healing, like emotional. So the first thing that we do when you come and see us is, first of all, we get your history. We try to understand how this occurred first and foremost. Then we explain to the patient that this is a 10-year process. Nobody just wakes up and gets diagnosed with cancer. Heart disease and cancer, which are the top two killers, started 10, maybe 15 years ago. So that means that you and I have a lot of work to do to unravel that. A little surgery, a little chemo and radiation is not going to unravel this chronic disease process. That's why all of us need to be great detectives in figuring out what your issues are. And we are very, very serious about that. So when you come in as a patient, we hear your story, then we do a physical exam, then we order initial blood work testing. Then the first two things I usually have my patients do, and the other doctors also, is we have to make sure that you're eating foods. There is no one that will argue that the foundation of any chronic disease is what you are eating. So if you're not eating the foods that nourish and strengthen and heal your body and optimize your immune system, you just can't get well. Then we believe that emotional conflict in any form or fashion, and all of us have it, okay? There's not a person that doesn't have emotional issues. And just being diagnosed with cancer is a traumatic stress. So we need to also get our head in the right place, because we can't heal. It's scientifically proven that if we're stressed in a sympathetic nervous system overdrive, that we can't heal. Even if we do surgery, chemo, or radiation, our body cannot heal. So we want to get to the patient in the right state of mind so that they are in a healing frequency, a healing mode. Then we will, after that, we will see what we first find out, and then we will develop a targeted treatment plan. So we're significantly different. That's what we're going to talk about.
Thank you for that thorough analysis of what we do and why we're trying to get to the root cause. We're trying to be detectives. We're trying to look at all these individual pieces over the course of your life that could have contributed to your cancer diagnosis, or are a risk factor for developing cancer in the future. So we know that our traditional therapies, like you mentioned, chemo, radiation, surgery, those are what people think of as our normal ways of treating cancer. And they have a time and a place, and they are definitely necessary in some circumstances. What people may not realize is when we do those therapies, we're only targeting cancer cells or tumors, right? Those therapies are like a missile going in and detecting those cancer cells and killing them off, and that's a good thing. However, that may not be good enough. And what we're finding in recurrent cases of cancer, and also in just the fact that we have so many new cases of cancer, that approach is just not good enough. It's a shotgun approach, and like many other illnesses, we're now realizing there were so many contributing factors. So can you, Dr. Connealy, explain a little bit more about, say someone went through chemo, they went through radiation, or they had surgery, they had a mastectomy, or they had a prostatectomy. They got a clear report from their oncologist, but so they think that they have a good clean-up bill of health now. They're out of the fire zone. What is something that they may not be aware of, that we can look at their overall risk, and maybe there's something brewing under the surface, and how do we test that? What are the testing modalities that we can use to say, okay, sure, you've had this initial treatment, but we want to still look at the terrain of the body, because if we don't address the terrain that the cancer occurred in, it's going to come back, or a new form will come back.
Right. And this is what we see frequently is patients have been diagnosed. The doctor has said, okay, you're good. Yes, they will do follow-up with some minimal blood work, but unfortunately, it's not revealing that the cancer is gone completely, or they may be tumor-free, but they're not cancer-free. So the definition of cancer-free is when you have circulating tumor cells of 0. That's the definition of oncology books in the United States today. So there's tumor-free and then there's cancer-free. So if cancer starts with one abnormal cell. That one abnormal cell in the right perfect conditions develops into cancer, and that starts duplicating until it becomes a tumor about 8 years, okay? So that means we have plenty of opportunity to prevent and fix cancer or reverse cancer because it takes so long to develop. So, but by the time it's 1 to 2 millimeters, which is about a quarter or a half of a BB, there's something called circulating tumor cells, and they're responsible for 95% of metastasis, the cancer coming back or metastasizing somewhere else in the body. So like Heidi said, if we didn't change the terrain, which is the water, all the cells are floating around, they're all talking to each other, they're all communicating, they're all taking care of you every day. But if they're not in the right condition, high sugar, toxicity, vitamin deficiencies, other infections, then it's going to have the same condition for cancer to reoccur. So it's that plus the circulating tumor cells. So we do special blood testing. We call it a liquid biopsy, but it's also, if patient's cancer has come back, it will tell us what the circulating tumor cells, but also it will tell us everything that works on the cancer. So a lot of times patients develop chemo resistance. They've already done chemo, but they have chemo resistant cells and chemosensitive cells all at the same time. So when you give chemo, at the beginning, wherever you go, you have cancer that is being responded to chemotherapy, but then you have all the cell population that doesn't respond. And the more chemo we give, the more chemo resistance we develop. So it's very important that the doctor, when they order your blood testing, that they look at this, and that we use a lab called RGCC. This lab is used all over the world by over 16 countries. In the United States alone, there's about 1,000 doctors utilizing the test, but it is absolutely necessary that every doctor checks circulating tumor cells. The labs in the United States I have not found to be effective yet, but we know that with the RGCC test in Greece, it is the most sophisticated oncological testing that we have utilized in the world. That testing gives us circulating tumor cells all the way, does radiation and heat work, does what natural things work, what chemo works, what specialized drugs work on the cancer, what blockers work. If you have prostate cancer, what testosterone blockers. If you have breast cancer, what estrogen blockers. So, and then it tells us all the markers of the cancer feeding the cancer. So I always tell people that cancer is like 100 leaks in the roof, and it's a tornado, rainstorm, hurricane, and you got to starve all those leaks so it doesn't continue to feed the cancer. Another area doctors don't realize that you have to cut off the blood supply. How do cancer cells survive? They survive because there is a blood supply feeding the cancer. Another big area that doctors don't address is the acidity of the body. We know that the acidity of the body is going to create a further environment of cancer. What causes acidity? First thing I always think about, stress. Let's face it, all people are stressed to an extreme degree. Maybe they've had serious situations where someone has died. They've taken care of a person with Alzheimer's for 10 years. Maybe they've had stress from a child. Maybe their mother and father, they're a caretaker for them, for 10 years. All these factors must be addressed, but it creates outrageous stress in the system. The other thing is, if your body is laden with viruses and yeast and parasites, you're going to have acidity. And these things are very, very easy to have. For example, why does Candida grow? Candida is a fungus. It grows because we're all ingesting antibiotics, not just prescribed from a doctor, but it's in the food supply. We all allow GMO foods. The GMO foods are not good for our microbiome. So that has to be addressed. So I know this sounds complicated and overwhelming, and it is, not only for us, but for you to understand. But little by little, I tell people it takes about a year to truly understand how your body works and how we're going to turn it all around. So patients don't understand that because their doctors just tell them, okay, we're just going to do this little procedure and everything's going to be great and wonderful. I would love for it to be that easy, but I've been doing this 34 years and I haven't found cancer to be an easy proposition. And it takes a lot of effort on both of our parts to be victorious over this disease. So I tell people, don't lose hope. We create the optimal roadmap for you to heal.
Absolutely.
So one thing I would like to add on is, besides circulating tumor cell that Dr. Connealy just talked about, we also do a blood work called nagalase level and also a blood work called PHI. And nagalase level is an enzyme that is secreted by viruses and cancer cell. What they do is they suppress our immune system, so our immune cell doesn't recognize the virus, doesn't recognize the cancer cell to go after them and engulf them. So we do that level on our patient and we monitor that. As that level is going down, we know our patient's immune system is getting better and patient is responding to whatever therapy is doing. And then also, if we see that nagalase level is going up, then we know, okay, patient's immune system is suppressed. We're not addressing the root cause. Maybe this patient has more viruses that needs to be treated, or is the cancer is not responding to the therapies. So then another blood work we always do, so we don't get surprised when cancer have metastasis, but none of these tests are 100%. So nagalase could be a normal with the stage 4 cancer. There is no test that is 100%. So it works like 85% of cases. Nagalase tend to be elevated, and also PHI. PHI is not 100% either. But the best thing to do is, if we see the patient before they get started on their chemo or before their surgery or any other therapy, we do a fasting PHI. If it's elevated, we know, okay, this is a good blood test for us. We could monitor this. So what is PHI? PHI is an enzyme that is secreted by cancer cells. It's a anaerobic response. So cancer cells who produce PHI, basically we know that patient is in an anaerobic state and the cancer is going to metastasize. There is no way a cancer will metastasize if the PHI is normal. This is in a case when patient has an abnormal PHI in the beginning of our blood work. So it's a great marker. Like so far, I only had one case that I was surprised that patient had metastasis without knowing, because of the patients who had elevated PHIs. Only one case, patient was doing therapies and the tumor was getting bigger, but the PHI didn't go up, is because this is a metastasis marker. It doesn't necessarily go up because that tumor is getting bigger. It goes up because the metastasis is getting worse.
Right.
So it's a fantastic marker. Like I had patients seeing their oncologist initially coming to us, having elevated, and then go to the oncologist, monitor. 4 months later, PHI goes up to 60s. So I'm like, you know what? We need to do the scan. We do scan, we see metastasis. So it's a great thing to do. And another testing we do is the biomeridian with Molly, which checks our acupuncture point, which checks us in the beginning of our process, and then we monitor with Molly every 2-3 months to see if we're going the right direction. So we don't only look at circulating tumor cell, because with the circulating tumor cell, sometimes, as we know, no test is 100%, it can hide in your bone, it can hide in your tissue, and may not float in your blood. And you can just rely, I have a low CTC, I'm fine. You can rely on that number. We do that, we do nagalase, we do PHI, we do Molly, we look at your overall blood work. How is your white blood cell doing? White blood cell is #1 marker of immune system. We see a lot of cancer patients coming to us with 10 years, 8 years, 15 years history of low white blood cells. And what is that sign of? this is sign of immune suppression. There's chronic infection going on in that body, which wasn't addressed. As Dr. Connealy mentioned, it could be viruses, it could be parasite, it could be candida, fungus, mold, or toxicity. Anything is possible. So I just want
We also
to add
look at
that on.
our scavenger cells, our natural killer cells too, is another big testing that we do, because we want to see, is your immune system able to go around and detect cancer cells before they form tumors? Is that broken in the body? Is that impaired to the point where your immune system, we know, is suppressed? And so we want to partner with you to really dig into what are all these contributing factors, and then how can we monitor them over time? And if we're only looking at PET scans, or only looking at mammograms, or only looking at basic blood work, we're going to miss these things that are a big piece of the puzzle.
Yeah, and as we know, cancer is a metabolic disease. So mitochondria, which is the organelle inside your cell, which you have like thousands of them in your heart muscle, and neurons, and 200 to 400, whatever number it is in your adult cells, they're not functioning right. And that could be as simple as heavy metals. Mitochondrial. Like I had one patient early on, she had low white blood cell, her PHI was elevated, and I saw her early, like 6-7 years ago. I saw she had very high mercury. So what did I do? I got rid of the mercury. First thing you do is get rid of the root cause. I mean, what is it that is patient eating fish? So you want to stop eating fish. Do you have amalgam filling in your mouth? You want to get rid of them. Then you get rid of the mercury out of the body, and then you see how the body is functioning. Her mitochondria improve as the mercury goes gone out, and her white blood cell gone up. She still haven't got anything, no diagnosis of cancer. But let's say we haven't addressed that heavy metal elevation. That mitochondria would have been dysfunctional. More mitochondria, body would have been anaerobic, and then some tumor would form.
Good.
So that's why we look at the patient as a whole, and we don't only deal with cancer patients, we deal with people preventive. They want to know if they have cancer, they want to optimize their body to not get cancer, since cancer now is one out of 3 women and 1 out of 2 men. So that's high. So, and we know cancer is due to epigenetic, environmental factor changing our genes. And 95% of cancer is due to epigenetic. So that means metals plays a key, viruses, parasite, emotional stress, everything we discussed plays it. Yeah, and if you don't get rid of this, let's say you are in remission according to your oncologist, recurrent gonna happen. It's just a matter of what, because those circulating tumor cell, as we discussed, hasn't been addressed. Oncologist says, yeah, let's do chemo. It's gonna go after all your circulating tumor cell. But then we do the patient's circulating tumor cell before and after. In some cases, yeah, they go down by a little bit. In some cases, it goes up. Like I had a patient who had lumpectomy and radiation. Before starting the procedure, her circulating tumor cell was 1. I said, I don't think that's a great idea to do lumpectomy and radiation. Let's do cryoablation, freeze it, and then we deal with the circulating tumor cell. But the patient wanted to go what the oncologist said, and after her therapies, then she did the CTCs, went up to 2.5, from 1 to 2.5 after lumpectomy and radiation. The reason is when you do surgery, what happens? Surgery suppresses your immune system. All your cells are going to that area to heal it. Now the circulating tumor cell that is floating in your body is keeping adding on and adding on. So that's why when I have a cancer patient, I say, in fact, if you're gonna go do a toe surgery or arthroscopic knee, I need to know, I need to prep you prior to surgery. So it's very important, because I had a case as well, prostate cancer patient who was doing great, he was stable, doing everything we recommended, but then he didn't even discuss with me when I did arthroscopic knee surgery, and then 3 months later, his prostate cancer flared up.
Yes. Very good
So
point.
we know that and we see that, and so as Dr. Connealy said, and as all we know here, that cancer is a systemic disease. Attacking one area with chemo, radiation, surgery is not the solution.
And it's a chronic disease.
And
It's
it is a
something that
chronic.
needs to be monitored all the time. Anyway, what were you gonna
And we
say?
have a test also that measures natural killer cell activities, the NK view, that we can I'm gonna add into that because I've seen like what you guys have seen with cancer patients, really low WBC, and I look at the absolute lymphocyte count because that's crucial in fighting cancer. And yes, there are a lot of things that can cause that, and we need to get to the root cause of it and eliminate it. But there are also, one of the things that I would like to mention is a chronic viral infection, which we don't have a blood test right now, the retroviruses that infects the lymphocytes by itself and causes some immune suppression. So one of the things that we need to do in this case is I add some peptides to increase the lymphocyte count, and that helps because it increases the natural killer cells, dendritic cells, T lymphocyte count, and it also has antiviral effect and anti-cancer effect. So that's one of the things that I would add to this regimen.
Yeah,
So-
like thymosin peptide.
Thymosin alpha 1.
Yeah.
Yeah,
Can
so-
you explain just for our viewers who may not be familiar with what is a peptide? How does that work?
Sure, now that we mentioned that. So a peptide is a chain of amino acids from 2 to 50 chain of amino acids. We call it peptides. Insulin is a peptide actually. It's similar to a hormone, but yeah. So thymosin alpha 1 is like so we have a gland here behind our breastbone. We call it thymus gland, and that's active when we are in pubertal age. That is the school of our immune system where T lymphocytes are trained to fight infection and cancer. But then as we get older, it shrinks to nothing. It's replaced by fat. So then you lose these peptides produced by this hormone, thymosin alpha 1, thymosin beta, and then there's prothymosin. So you lose that. That's why older people are prone to infection and cancer. So basically what we're doing is just replacing it with a peptide or hormone.
Wonderful.
Yeah, that's not a drug. It's not a drug. It's just a peptide, which is a sequence of amino acids. So, but it's phenomenal with helping patients because, as Dr. Acebedo says, everything's about your immune system. And as we age, we have pausing. I call it pausing of the entire body process, whether it's the brain, the liver, the kidney, the immune system, everything pauses. So now we have to do optimization and preventive medicine because that is how you stay well and out of the emergency rooms and out of hospitals.
And one good thing about the peptides is you can do these therapies at home. They're oral or they're subcutaneous injections that you can actually do at home. It's not a treatment that's invasive. You don't have to come to a clinic for it. It's something that you can do at home every day that will boost your immune system and can also be used with chemotherapy.
Yeah. I actually have one patient right now who is undergoing conventional chemotherapy, and he's older. He's about 70 years old, so I'm just supporting his immune system. He's on this peptide, and he's had multiple chemotherapy sessions already, and so far the white count is staying up there. So
Yeah, I see
amazing.
that too.
So what is the place of chemotherapy? So there is a place for surgery, but what makes us different is that, as Dr. Bita said, we prepare the patient mentally, emotionally, and physically. Because I've had surgery before, and I did lots of preparation before. Mentally I did, and doing lots of meditation, how great the surgery is going to be and how wonderful the outcome is going to be. And then I did IV vitamin C, and I did hyperbaric, and all the nutritional supplementations for my immune system and for my body to work well. So as Dr. Bita said, all of us need to do that. I don't care, even if you've never even had cancer, but especially if you've had cancer, because surgery is a very, even getting a facelift is a very immunosuppressive, injurious process. So make sure that if it's not one of us, make sure that a functional doctor is preparing you before, during, and after the procedure. I had 18 hours of back surgery yesterday, so I've been for the last year recovering my body on all levels and doing many things. I personally do the thymosin myself. So not to mention optimal nutrition, IV vitamin C, hyperbaric. So now chemotherapy. Some of our patients, when would we do chemotherapy? Well, there's the conventional chemotherapy that the oncologists we work with, they do, but also when you do chemotherapy, we learn from taking courses in chemotherapy that it is injurious to all bodily processes. So that means that we've got to fortify you and do everything we can so that your body can handle the chemotherapy.
So we're all aware that chemotherapy is a very standard treatment for cancer, but what you may not be aware of is we have another way of doing chemotherapy that is much better tolerated, can be much safer, with a lot less side effects. Can you tell our viewers what that chemotherapy looks like and how it's different? How do we utilize chemotherapy in a way that's a little bit different that they may not be aware of?
Yeah, so our clinic values Hippocratic oath, which is first do no harm, right? So we find ways to, treatment that would minimize side effects. So one of the ways that Dr. Donato Garcia discovered, and it's called insulin potentiation therapy, which is a low dose chemo, which is 10% of what typically conventional doses are given. And it was discovered in the 1940s. Initially, he was using it for syphilis treatment, but then he also discovered that it also works for cancer. So he trained a lot of doctors now, and we are one of those facility that uses insulin potentiation therapy, and it's based on the premise that cancer cells eats glucose and has 6 to 10 times more insulin receptors compared to the normal cells. So how that works is we give patients usually have to fast overnight, and then we measure the blood sugar initially, and then we give the insulin. At a certain point, once they feel the signs and symptoms of low blood sugar, that's when we give the chemotherapy drugs by IV push. And that what happens is at the molecular level is once the insulin attaches to the receptor, it stimulates the insulin receptors and the insulin-like growth factor receptor in the cell and causes cell membrane permeability, and then it drives the synthesis phase, or the S phase of the cell cycle, and that's when the cancer cell is vulnerable to treatment. And that's what we're trying to do here, is to kill cancer cells as much as possible with less side effects to the normal cells. That's basically how it works in summary. So
Yeah.
Let me just add something. As we mentioned, nothing is 100%. It doesn't use for every patient. So what we do is we evaluate our patient. I had a patient coming from Mexico going to the therapies and did the IPT there, but she had no response. And one of the reasons was the doctor didn't even pay attention to the patient's PET scan, that the cancer didn't light up. And what does that mean? There is a glucose metabolite they give the patient, which cancer cell uptake it, and they light up. So patient had no sign of cancer on the PET scan, and then but went and did IPT and had no response. So we know that people who don't metabolize cancer via glucose and use glutamine instead, they're not gonna benefit from insulin potentiated chemo. Let's say a patient says, you know what, I don't want to do a PET scan. I know it's just here and I'm HER2 positive and I have high Ki-67, which means my cells are dividing fast. They're going to respond very well to chemo. I want to do that. Then we do, okay, we don't have to do PET scan. We do the RGCC testing that Dr. Connealy talked about. And on that testing, it shows us insulin-like growth factor, IGF-1, IGF-2 receptors, and how much percentage they are. If the percentage is high on them, it's mutated, it's red, then that means yes, IPT would work for them. But if that's normal, then we say, you know what, that's not an option for you. So that's one of the things I would like people to get educated, because you can't just think, okay, it's better to go to Mexico, get everything done. It's, you want to know why you're getting this treatment, what kind of testing was done. Does the doctor, I know maybe IPT does interest you, but you can't just go to a doctor and ask for it. As a physician, we have to decide if it's the right decision. I had a patient yesterday, stage 4 breast, mets to the brain, and had the area had a cryoablation.
Explain the cryoablation.
Cryoablation basically is they go in there and freeze that tumor. And she wanted to do cryoablation even though she was stage 4. And then they wanted to radiate her brain. And she said, I want to do IPT, but then her history was she had history of IPT in a different state with a different doctor. And the case, she didn't respond well. She progressed. So as a physician here, I have to decide, IPT is not the right case for you. It's not for everyone to decide they want to do it. It sounds good, less side effect. Each individual has to be really evaluated, and as a physician, we decide. And if there is a case, I don't know what to do, I go to our doctor's meeting, which we have every Wednesday. We have a conference room, and all of us talk about each cases. We discuss what should we do next, what should we do with this patient. So I just wanted to add on, IPT is great, and there are testing we could do, but we need to evaluate the patient for it.
I'm gonna add into that, now that they're coming up at Johns Hopkins, they now have glutamine PET scan, which doesn't use glucose there. So it's just, it's in early stages and they're doing experiments in it. So hopefully in the next 5 or 10 years, it will be available to all of us, so.
Yeah, and that's those cases who don't light up on PET scan, then we will send them for glutamine.
So, yeah, because what I'll clarify is, just because you do a PET scan, first of all, you're not going to find all the cancers because the size is 5 millimeters and above. So everything less than 5 millimeters you're not going to find. That's number one. But number two, if the cancer cell doesn't feed off sugar, the cancer will not be found, because that is what the PET scan is. It's using sugar for the insulin receptor sites to light up. So if they don't use sugar, that is not going to appear on the PET scan, and you'll have a false sense that you don't have any tumors or lesions in the body. Why don't you talk about mistletoe and how long it's been around and everything?
Right. So mistletoe's been around for 100 years now, and they just celebrated 100 years actually last year. It was discovered by a Swiss physician. I don't exactly remember now, but they've discovered that a lot of the components in the mistletoe, as lectins and other components there, that stimulates the immune system. It has anti-aging benefit, also has anti-cancer benefit. So in essence, it also stimulates the immune system, and in essence kills the cancer cells. And so there's so many ways that we can use mistletoes intravenously, and we use that a lot in our clinic. We can use it subcutaneously, which a lot of our patients, after they're done with IV, then they go home and start the subcu injection. But we can also use the mistletoe directly or around the tumor cells to stimulate that area. So then the theory there is to stimulate the immune system so that when it's very close to the tumor area, they can see the tumor and starts attacking it. And that's basically the premise and the theory there. And I know a lot of doctors have used mistletoe. A friend of mine in Malaysia, he used the mistletoe with a lung cancer, and he injected the mistletoe directly into the pleural using a Pleurex catheter, and he had good results with it. So I know a lot of other doctors are using it by adding some saline mixed with mistletoe and infuse it directly into the tumor area.
To add on, the way we monitor the patient when they start using mistletoe, we slowly increase the dose, and then their body temperature goes up. Patients tend to have low body temperature, cancer patient, because of whatever reason it is. If their thyroid is suppressed, adrenal is suppressed, and chronic disease, chronic infection in them. So the mistletoe will slowly activate and elevate the patient's body temperature. And sometimes it even induces fever and chills. Mm-hmm. And that fever and chills last for a night, and next day they feel fantastic. It's because they activate the natural killer cell, and now natural killer cell is going and engulf the cancers. And we see that in patients even going through chemo. Most of the time I put them on mistletoe. And the ones who develop that reaction, fever and chills, with their chemo, they have the best response. Their tumor shrinks much faster. So it's amazing.
That's one of the indicators that we know that your body's still reacting to mistletoe by checking your body temperature. Our protocol is, it says 4 times a day while you're on the mistletoe, so you'll know that you're still reacting to it. Because at some point, if you stay on the same dose, that's why your protocol is different. You go up and down because you develop tolerance to it. Your body develops tolerance to it.
Yeah.
So it's important that you go up and down the dosage as when you're in the maintenance phase.
You're talking about subcutaneous.
Talking about subcutaneous.
Subcutaneous. In terms of IV, that dose that you reach, it does last, but you don't do it every day. You do it 3 times a week or whenever day of chemo is, like patients doing conventional chemo set. Once they're done, they come to our office, get that mistletoe going.
Mm-hmm.
And then also we're starting to help patients detoxify, right?
Yeah.
So they're going through all these treatments, whether it's conventional, whether it's alternative. We have to help the body detoxify all these things. So there's various ways to do that, but in the process of going through these treatments, we're also going to be detoxing all these things, clearing up the liver, getting rid of all this cellular debris so that we're creating this healthy environment again. And as you can tell from our conversation, we have so many treatment options here, a wide variety of treatment options, a wide variety of testing, and we want to partner with you each step of the way. So whether you're healthy and you want to prevent cancer, you have a family history of cancer, but you don't want to get cancer, we want to work with you right now to get your body optimized with you. And that means we want to continue to monitor you closely and continue to look at where are those missing pieces. The roof has 100 holes in it, and we're gonna, over time, patch each of those up. One thing I wanna mention that you may not be aware of is in 2018, we had a law passed called the Right to Try. What that means is we now have a law in place in the United States that allows you to get alternative therapies in this country. So you don't have to travel to Mexico or Europe or some other country to get these services and these treatments and these testing options. We have that here under one roof, and we have the ability now to partner with you each step of the way and offer these services that you used to not have the option to do here in this country. So I want to invite you to check out all of the options here at our clinic, the Center for New Medicine, and we invite you to partner with us and help so that we can help you optimize your health.
Another thing I want to add on to that is that patients should know, if they had cancer 10 years ago and they believe they're in remission, they're not doing anything about that. We see patients 29 years later, 15 years later, developing recurrent. And we could monitor those patients. We could do circulating tumor cell. We could do fasting PHI. We could evaluate them, see what is it that caused that cancer from the beginning. So it's important that patient realize it's not just thinking, oh, I done my chemo, I done the conventional, I'm done, I'm good to go, I'm in remission. According to my oncologist, 95% chance that I'm cured. Or, I don't believe it's such word. It's not such thing as cured. Being cured, cancer, as we said, is a chronic disease. It's always going to be in us. Like I have stage 4 patient. Now, he went through last year, young guy. The surprising is we see so many young people now developing cancer is because that fetus, that baby, that person even now, before being born, that mother had more than 250 chemicals in the placenta. And then that baby is born and gets, other exposure of chemicals. And that causes mitochondrial dysfunction and exposes that kid and the baby getting cancer later on. So we see a lot of 20, 30-year-old people now with cancer. So this guy was 32, last year diagnosed with colorectal. They went ahead and removed it, chemoed it, radiation. 4 months later, back, same area, and then they gave him more chemo. Then 4 months later, went to the lungs and liver, and then chemo more, he got more chemo. By December, he had mets to the bone, more chemo, radiation, or immunotherapy, I can't exactly recall, but by March, mets to the brain. So now they still recommend, let's do radiation for your bones to get rid of the pain. So I said, you know what, there is more option to do. And that was a week ago. I saw him yesterday. That was a big difference. He didn't look that toxic. His pain level already improved with 1 week of therapy. And I say patient cases like this, You want to go day by day, enjoy your life, increase your energy. It's not about thinking, I want to wipe that cancer, let's do this, let's get rid of it. No, there's a lot of therapies you could do to keep that cancer stable and live with that cancer. You don't need to be afraid, oh my God, I have this tumor, I need to get rid of it, cancer all over. No, it doesn't work that way.
And the treatment can't be worse than the disease.
Right.
Yeah.
So it is our job, like Dr. Acebedo said, the Hippocratic Oath, who is the father of medicine, said, first, do no harm. And so that's how we operate every day. We don't want to injure and hurt our patients. We want to heal them, we want to optimize them. And every individual is an original. So you're your own clinical trial. And that's why we dissect every single thing about each person to ascertain what is the best roadmap. So all of our patients aren't getting the same things. Yes, there are some common denominators, like, is the person stressed? What is your sleep? Water, eating, movement, and purification, as we said. Those are foundational for every one of us, whether we don't have cancer and we're healthy or we have chronic diseases. You must follow the rules and laws of the body. So I would encourage everyone to get the Cancer Revolution book. It explains all of this in detail. The more you understand and operate out of really understanding and knowledge, the less you will fear.
And we really want to just say that we want to partner with you, we want to educate you, we want you to understand each and every option that you have. You need to feel comfortable with the treatment that you're doing, and you need to feel secure, and you need to feel like you can partner with your provider. And so that's really the environment we want to create here. We want to walk with you, we want to educate you, we want you to come in with questions and for you to do your research and look at all these various options, because there are many out there. And we really want to create an environment that is a true partnership, because I believe that that's really how we get people better. You know, you can't get better by yourself, and it takes a village really for us to live our best lives. It takes a village to get patients healthy, to turn things around. And so we invite you to partner with us and to become educated.